everyone, welcome to Fast 5 at RSNA22. Your colleagues from around the world submitted their ideas covering a wide range of non-clinical topics to participate in this engaging and fast-paced session. After our voting process, where all topics were considered, 5 speakers were chosen to present today. Each speaker will have 5 minutes to present on a topic of their choice that reflects this year's RSNA 2022 theme, Empowering Patients and Partners in Care. Let's begin. I am your moderator, Wang. Dr. Sam Galgano serves as the Section Chief of Abdominal Imaging and Director of the Abdominal Imaging Fellowship, and Vice Chair of Quality and Patient Experience at the University of Alabama at Birmingham. His research interests include improving cancer staging of gastrointestinal and genital urinary cancers, enhancing quality of radiology reporting through structured reporting, and optimizing peri-procedural and procedural technique and outcomes. Dr. Galgano's topic is palliative care in radiology, more than meets the eye. Please welcome Dr. Sam Galgano.
Thank you, Sherry. Thank you all for attending my talk. My goal for the talk is to kind of just familiarize with people with what palliative care is and how we really are a part of palliative care. So my only relevant disclosure is that I'm married to a wonderful palliative care physician who, 1, provides me an immense amount of support, but 2, and more importantly, has taught me a lot about palliative care along the way. I would be remiss if I didn't have a chance to mention the rest of our procedural team, most particularly our lead PA and our lead procedural sonographer. The 3 of us have had some pretty intense emotional moments along the way, and without their support, things would have been really challenging. So I'm going to start with a couple patient scenarios to set the stage. A woman with 2 children is recently diagnosed with metastatic gastric cancer. A man with cirrhosis is just trying to spend some time at the beach. A grandmother with metastatic breast cancer is just trying to make it to her granddaughter's wedding. And finally, a young woman with colon cancer presents for paracentesis the day prior to her wedding. So what is palliative care? Well, the American Association of Hospice and Palliative Medicine defines it as focused on improving quality of life through relief of pain and other distressing symptoms throughout the course of a patient's illness. Simply put, palliative care is a lot more than hospice, and it spans from the moment a patient is diagnosed with a serious illness until they die. And so you may be wondering, how are we part of the palliative care team? Well, the palliative care team is multidisciplinary by nature. It includes physicians, it includes psychologists, it includes chaplains, and others too numerous to count. But where is the radiologist? Throughout the course of patients' illness, patients come to the radiology department for imaging and interventions. These services we provide offer promise and optimism in response. They offer sadness and despair at time of progression, and some of the services we provide offer them relief of their suffering. Given radiology's central role in multidisciplinary conference, these complex patients are often the center of discussion. And so as I've briefed you on palliative care, you can see that radiology and palliative care are not all that dissimilar. So the patients I talked about are not really unique to any specific radiology department. I personally perform procedures every Wednesday, and so that gives me an opportunity to see patients more than once on a recurring basis. And these visits are very different than all of their other medical visits. There's no agenda. I don't have to check any boxes. The only thing we have to do is to do the procedure. And so during this, it gives us a chance to do something unique. And this is where I really feel like we could add value. The ability to sit down and connect with patients on a human level while they're getting this done. I've laughed with patients. I have cried with patients. I have had some very challenging conversations with patients about death, dying, and kind of what the future will hold. And it's tough, and it doesn't come easy, but by having this lack of an agenda, it really gives you a unique opportunity to dedicate some time towards this. In doing this, you build a relationship with a patient, and it leads to me selectively wanting to read their restaging studies. It leads to me wanting to advocate for their care at multidisciplinary conferences, and I have done so several times successfully. So we have about a minute left. What are the takeaways? How can you provide palliative care in your next patient encounter in radiology? Well, I would say there are 3 important concepts to keep in mind. 1, be present in the moment. 2, be human, and be human with the patient. And 3, and most importantly, be willing to be vulnerable. And I specify emotionally vulnerable. By doing these things and keeping these things in mind, you're really able to develop a personal relationship with these patients, which will reap great rewards. And as proof of this, for my final slide, I just want to share with you a letter of thanks I got from a dying woman at the last paracentesis she got before she went on hospice. Thank you.
Dr. Beth Vettiyil is an assistant professor in musculoskeletal radiology at West Virginia University in Morgantown, West Virginia. She previously served as a chair of radiology at Central Southside Hospital in Virginia. She is also an associate editor for radiology case reports and an assistant editor for RSNA case collection. She enjoys swimming, playing the violin, and creating educational content on YouTube. Dr. Vettiyil's topic is increased patient access to radiologists. Please welcome Dr. Beth Vettiyil.
Hi everyone, my name is Beth Vettiyil, and today I want to talk about a topic that I feel very passionately about, and that is increasing patient access to radiologists. Before we begin, let me tell you about a little incident that happened at the NFL playoffs a couple years ago. So NFL stands for the National Football League in the United States. At this particular game, a player got hit in his abdomen with a helmet. He recovered enough to where he was going to be cleared to get back in the game. One of my mentors was on the scene, a team radiologist with the NFL, and he felt something was wrong. So he quickly ran his ultrasound probe over the player's abdomen, and boom, the player had a splenic laceration and was bleeding into his belly. The radiologist may have saved his life. This anecdote underlines the fact that all of us radiologists are amazing physicians, and our patients will really benefit from having increased access to us. Access outside regular reporting and without necessarily involving the ordering physician. A study from Emory University, published in AJR in 2018, shows that 96% of patients find direct communication with radiologists helpful. 96%. And on the other side, a study from Europe, published in European Radiology in 2021, shows that radiologists may have to go back and correct their reports in 42.6% cases after direct communication with patients. Which means if you read 100 studies and then spoke to those patients, you may have to go back and addend at least 42 of your signed reports. So what do? How do we just talk more to patients? So we can have virtual options and in-person options. Virtual options can be an email model or online portal model or a telephone televisit model. In-person options can be a dedicated radiology clinic model or, my personal favorite, a collaborative clinic model where all the physicians in a patient's care team would come together to engage with the patient. Let's say there's a cancer patient. So the oncologist, the oncology surgeon, the radiologist, the radiation oncologist would all come together at the same time to consult with the patient. Now, I know what you're probably thinking. Who's going to pay for this? So CMS 2021 lets us radiologists bill for consulting as long as we have a physician-patient relationship. More importantly, we can build our brand as radiologists, which means more referrals and more revenue. It'll be a good public relations move for us to literally step from darkness into light. We can bust the myth of radiologists hiding in hospital basements behind computer screens. It'll make us irreplaceable. Giving patients increased access to us would really help them understand their disease process better, which in turn would empower patients to take responsibility for their medical choices, which in turn would encourage active patient partnership in their own healthcare. Thank you.
Currently a radiology resident at Stanford Healthcare, Dr. Sanna Herwald is passionate about balancing radiology fulfillment and wellness with the ever-expanding role of radiology in patient care. She is the recipient of a 2022 Society of Interventional Radiology Resident Research Grant and is excited about using novel technologies to make image-guided interventions even more minimally invasive and patient-centered. Dr. Herwald's topic is Compensate Radiologists for Tumor Board Participation. Please welcome Dr. Sanna Herwald.
Tumor board is the epitome of multidisciplinary patient care, where physicians from multiple specialties come together to discuss the most challenging diagnostic and treatment decisions in modern medicine. Although radiologists are key to the function of tumor board, they are not directly compensated for their contributions to this service. I would like to discuss 5 reasons why we should establish a payment system for radiologist participation in tumor board. Firstly, participation in tumor board requires significant radiologist effort. For example, during an average week at an academic hospital in Germany, there are 17 tumor boards, requiring 33 radiologist work hours, or nearly the entire workload of a single full-time radiologist. And the number of cases at tumor board is likely rising. For example, at one U.S. tertiary care hospital between 2019 and 2020, there was a 70% increase in the number of cases presented at head and neck tumor board. Among other reasons, this increase in the number of tumor board cases may be because certain medical societies are now requiring tumor board presentation for certain patients. For example, the National Accreditation Program for Rectal Cancer now requires tumor board presentation for all patients with primary rectal cancer. Secondly, radiologist participation at tumor board contributes to patient care. Even in this virtual era, when non-radiologist physicians can review patient imaging on their own, the demonstration of patient imaging findings at tumor board is considered, quote, crucial. And this interactive imaging interpretation translates into improved patient care. For example, after one hospital started a specialized tumor board for patients with early rectal cancer, these patients were more likely to have appropriate preoperative imaging and accurate preoperative staging. Thirdly, the imaging interpretation at tumor board is an independent contribution, not just a summary of the original read. For example, for up to 20% of patients presented at hepatobiliary tumor board, there is discordant imaging interpretation at tumor board, which is significant enough to affect patient management. Similarly, the staging of rectal cancer changed in 7%, or about 1 in 15, of patients presented at one tumor board. And this isn't surprising. Non-radiologist physicians also frequently disagree with each other. As one example, patients with spine metastases presented at tumor board were frequently not treated according to published multidisciplinary group algorithms. Therefore, similar to the second opinions offered by non-radiologist physicians, the second review of patient imaging at tumor board offers new insight beyond the original imaging interpretation. Compensation for tumor board participation would likely require documentation. If we can succinctly document how our imaging interpretation at tumor board differs from the original imaging interpretation, or if it is exactly the same, there would be several benefits. We all know that a single set of pixels on the screen can have different meanings depending on the clinical context. Fortified by the wealth of clinical information available at Tumor Board, we have the opportunity to provide the best possible interpretation of the patient's imaging. Also, what is discussed at Tumor Board is not legally protected. By clearly documenting the imaging interpretation and recommendations we made at Tumor Board, radiologists have the opportunity to protect our statements from misinterpretation. Similarly, clear documentation ensures that our non-radiologist colleagues clearly understand and remember the imaging interpretation and recommendations that we made at Tumor Board, which ultimately helps our patients. I will summarize the 4 reasons already discussed and end with the 5th reason why we should establish a payment system for radiologist participation in Tumor Board. Firstly, Tumor Board participation requires significant radiologist effort. Secondly, radiologist participation in Tumor Board contributes to patient care. Thirdly, the imaging interpretation at Tumor Board is an independent contribution, not just a summary of the original read. Fourthly, compensation for Tumor Board participation would likely require documentation, which helps radiologists to protect ourselves and ultimately help our patients. And finally, I would like to acknowledge that participating in Tumor Board is the right thing to do regardless of compensation. But compensation would support radiologists doing the right thing so that Tumor Board participation becomes more widespread and sustainable. Thank you.
Dr. Peter Abraham is currently a resident physician in the Department of Radiology at the University of California, San Diego. He attended UC San Diego School of Medicine and completed a master's in advanced studies in clinical research. His research interests include health services research with a focus on disparities, health policy, and cost effectiveness, as well as diversity, equity, and inclusion initiatives. Dr. Abraham's topic is Achieving Health Equity and Healthcare Systems Transformation through Meaningful Community Engagement and Upstream Partnerships. Please welcome Dr. Peter Abraham.
Thank you. It's my pleasure to speak with you today about engaging patients and community towards health equity. The Institute of Medicine defines health disparities as that portion of health differences which is not due to individual patient choices or clinical appropriateness, but rather due to the operation of the healthcare system or discrimination. In radiology, disparities exist for a number of patients belonging to vulnerable populations, and patients existing at the intersection of these populations carry the highest burden. We must, as radiologists, leave the reading room to undergo the root cause analysis for these existing disparities. Utilizing a wider community-based understanding of health will illuminate some of the upstream factors responsible for our health disparities in our patient populations and provide actionable foci for us to intervene and decrease these disparities. So how do we begin to mitigate or unpack this complex system? I have a few simple thoughts I'd like to share. First, instead of solely thinking about radiology in terms of the diagnostic process, we can increase our attention and resources towards thinking about the patient journey, which improves patient engagement. In this imaging journey, many of the disparities that we're concerned with in our patient populations are due to the social determinants of health, the conditions in which we are born, grow, live, work, and age. These conditions are paramount as they account for the vast majority of differences in health, and targeted interventions toward unmet social needs can decrease health disparities. A few examples to make it more palatable. We can mitigate unreliable transportation by bringing patients to our imaging centers, by leveraging upstream relationships with municipal authorities for public transportation or private rideshare companies to bring patients to their imaging visits. Alternatively, we can take imaging out to our patients in our communities, utilizing mobile imaging services, such as mobile mammography, or increasingly other modalities as well. We can overcome or ameliorate some of the differences and disparities associated with decreased health literacy and limited English proficiency by documenting patients' preferred languages during visits. We can use that information to give them concordant educational materials, consent forms, and future utilization of materials. We can combat some of the difficulties associated with lack of childcare and paid time off from work by opening our clinics to our patients during nights and weekends and offering childcare services in our medical facilities where possible, whether directly through the facility or leveraging with other partners. We can mitigate some of the unknown and the concern associated with financial toxicity by giving patients materials which aim towards price transparency, giving estimated out-of-pocket maximum costs for both insured and uninsured patients. And where that is not available, we can utilize online comparison tools for our patients to get the best deals for the appropriate care that they require. Finally, we can increase trust in the medical system and in radiologists by having consistent positive impact in our communities outside of the reading room. Thank you.
A radiology resident at the University of Texas Southwestern Medical Center in Dallas, Texas, Dr. Ali Tejani serves as a member of the trainee editorial board of Radiology Artificial Intelligence and is the deputy editor of the Radiology Artificial Intelligence podcast. His research interests include AI education, natural language processing, patient-centric metrics for monitoring AI, and infrastructure for clinical AI. Dr. Ali Tejani's topic is Bring Patients to the AI Table. Please welcome Dr. Ali Tejani.
Thank you, and good morning. My name is Ali Tejani. I'm a radiology resident at UT Southwestern Medical Center. I'd like to take a few moments this morning to speak to you about a topic close to my heart, bringing conversations about AI to our patients. Now, this isn't the first time you've heard about AI, and it's most likely not the last. And we're talking about all the right things, like AI monitoring and the ethics of AI. But let's take a few moments to think about how we can bring these conversations back to our patients. So let's start with a scenario. We're getting ready to deploy an AI algorithm. So you get your team of stakeholders together. You have your radiologists, your non-radiology clinicians, technologists, members of the business, finance, IT, and data science teams, vendors, and our medical legal team. Well, this is pretty thorough. I think we're ready to tackle problems impeding patient care and improve patient outcomes. But wait, where's our patient? How are we letting them know about the use of AI in their care? Are we telling them? And if so, what should we be telling them? Importantly, are we thinking about how to take patient feedback to inform our continued use of AI? Now, I know some of you are thinking, maybe there's something here, but it's just too early. We're just finding out ourselves that AI can predict race and gender from radiographs. There's so much we don't know, and that's absolutely fair. But our patients also don't know, and they're finding out from non-vetted resources. And we're moving from theoreticals to objectives on patient perspectives on AI. If we take a look at this survey, just last year, from the Journal of the American Medical Association, we see 90% of patient respondents said that they had heard about the important role of AI in their care. 70% said they were uncomfortable with AI making a decision without an explainable reason. When we dive into the reasons for their concern, you see worries about confidentiality, misdiagnosis, decreased time with the physician, and increased healthcare costs. Note the discrepancy here along this board, as members of ethnic and racial minority groups rate a higher level of concern in each of these categories. This takes us to our next discussion point, that not all patients will have the same experience with AI. Let's take an example from my home institution, where we have a unique privilege to treat two patient populations. On one hand, we have our safety net hospital. On the other, we have our tertiary care center. Patients at the safety net hospital may not have the same level of health literacy or ability to select between several different sites offering AI solutions. Those at the tertiary care center, on the other hand, may actually bring up AI in their conversations, and they have, based on what they hear in their social circles. Another important point is that at the safety net hospital, many patients are aware of times in the past where the healthcare system has unfortunately failed them. And this can naturally translate to a mistrust of AI. One commonality, though, is the omnipresence of the lay media influencing patient perspectives. We as radiologists are poised to take control of this conversation, to serve as stewards of this technology. We have a responsibility, a mandate, to serve as trusted, evidence-guided resources for the use of AI in their care. And importantly, to bring their feedback to inform our continued ethical and effective use of AI. So now you're probably thinking, well, when do we engage with patients? Is it after defining the clinical problem? Maybe it's after curating and annotating data, getting ready to ask for patient consent. Or is it after we've done all of these processes, now saying we're using your data to train and fine-tune our models? Well, if you ask me, this process should start and end with our patient with checkpoints along the way to ensure two-way communication. As we conclude here, let's take a look at what this may look like in practice. This is an AI model card from our colleagues at DASA in Brazil. They detail indications, limitations, results, a visual aid, and an opportunity to provide feedback for our deployed models. Now, this is for non-radiology clinicians. Can you imagine the power of something like this for our patients? By simply asking our patients about their thoughts, we can bring significant meaning and value to the work that we do with AI. As we finish here, I'd like to predict that it won't be uncommon for patients to select among care providers based on AI partnerships and those they trust. I'd like to call on each of us to think about how we can bring these conversations to our patients. And maybe it's too early to directly engage with our patients, but let's converse together. Let's talk about governance. Let's talk about how we're making AI access equal across all patient demographics and geographic locations. Thank you for your time. Enjoy RSNA. It's been an absolute pleasure speaking with you.
Thank you all for joining us for RSNA 2022 Fast 5. We hope you are all inspired by the many ways today's speakers are empowering patients and partners in care. So next up, we have our plenary session.